Okay, how we doing in the room there? John, are we ready to go?
I'm just waiting on Heidi.
Okay, Heidi's not in the room yet.
Mark, what are we having for dinner tonight?
We're going to do Chinese tonight. I got some wontons and some vegetable over there cooking.
I can smell it from here. Looking forward.
No one leftovers.
Good morning.
So Heidi, you let me know when you're ready and I'll call the meeting to order.
I think we're all set.
Thank you. Okay, this is the Kern Valley Healthcare District Board of Directors meeting for Wednesday, August 5th. We are now in open session. The first order of business is the approval of the agenda. I'll entertain a motion.
So moved.
So we have a closed session report.
It comes later. That's further down on the agenda.
I got you. Okay, sorry.
So John, did you move?
Yeah, Barbara seconded.
And Barbara second?
Yeah.
Okay, we gotta do a roll call vote. John?
Yes.
Jean?
Yes.
Barbara?
Yes.
Charlie?
Yes.
And this is Ross Elliott, yes. Okay, and flag salute. Jean, could you lead us in the flag salute, please?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
And Chet, I have not asked you in advance, but could you please do an invocation for us?
Sure.
Thank you.
Glory to God, Father. We've found this evening at the regular meeting of this Board of Directors of the Kern Valley Healthcare District. At this time, Father, we pause, give you thanks for those blessings that we have received of thee, that our healthcare district is in fact healthy and well and moving forward. We ask that you, in that spirit, keep it moving in that direction, to ever have us improve our performance, improve our abilities and our skills and our technology to deal with those issues and illnesses and injuries that are prevalent or that happen to those that seek our care here in the Kern River Valley. Help us always to be the vehicle that is here and available and close at hand to those who visit or those who live here. That we might do it in a way that we can bring to their betterment the best healthy lifestyle possible under the circumstances. These favors and blessings we ask this evening, requesting that we might be united in our efforts. In the name of thy Son, Jesus Christ. Amen.
Amen. Jean and Chet, thank you both. I appreciate that. Okay, our mission statement is that we will provide high quality, efficient patient care services that respond to community and provider needs. We will provide leadership and health promotion and education for our patients, residents, medical staff, employees, and the community throughout the district. Okay, Scott, our closed session report. Are you still with us? There you are.
I am. In closed session, council and the board discussed negotiations for the purchase of property at 12424 Mountain Mesa Road. The board gave direction to council and no other items were discussed.
Thank you. Okay, this portion of the meeting is for public comment. The public may address the board on any matter not on this agenda, but under the jurisdiction of the board. You can ask questions for clarification, make a referral to staff for factual information, or request staff to report back to the board at a later time. Also, the board may take action to direct staff to place a matter of business on a future agenda. The board cannot take action on items not listed on the agenda. Speakers are limited to 3 minutes. Do we have anyone interested in making comments to the board? Any member of the public? Okay, I don't see any. So then we will move to the consent agenda. Item F on the agenda. These are considered, these items, all the items under the consent agenda, all the bullet points are considered routine and non-controversial by staff. Anyone, whether it be a member of the staff, a board member, or the public, can request that an item be removed from this agenda so it can be discussed and deliberated openly. Otherwise, all these items will be approved in one motion. Are there any items that anybody would like to see removed from the consent agenda? All right, hearing none, then I'll entertain a motion to approve the consent agenda.
So moved.
All right, Director Blythe, is there a second?
Second.
Director Casas? Okay. Then for a vote, Director Blythe?
Yes.
Director Parks?
Yes.
Director Casas?
Yes.
Director Bush?
Yes.
And Elliott votes yes. Okay, the consent agenda is approved, which moves us to item G on our agenda, which are the reports. When we begin with a foundation report, Tim, are you on for that? Oh, there's Debbie.
Hi, good evening. The only report I have is the River Rhythms we have opted to cancel. So it's canceled for this year. We are looking to perhaps continue with Crab Fest, but we'll make a determination in about 2 or 3 weeks on that. That's my report. Any questions? Thank you.
Thank you, Debbie. Okay, auxiliary report.
The auxiliary has been closed, so I'm not sure if they have a report today.
Okay, very, very well.
Heidi, did you get one?
Her report is on your desk.
Where on my desk?
Which pile?
Look on your right-hand side.
Oh. Got it. Good evening, everyone. Sure you missed giving these reports to you in person perhaps next month. Not a lot has been going on with the auxiliary. At our July board meeting, we had 3 interviews for the ladies to start their training July 27th, but unfortunately we had to close again due to the government recommendation. But prior to that, we were open on Mondays, Thursdays, and Saturdays. But in those 3 days, we were able to make as much as we did in 5 days before. Thought that was pretty awesome. We had our new gate opener installed. What a relief that has been, as the gate was getting harder and harder to move. We also had window awnings installed. That sure made a big difference with the sun coming in the windows of the storefront. Today, when I went to the thrift store, the front side window was out of track. Filed a report regarding that issue about there was no entry gained, so just a report was taken. Ellen has been coming to the gift shop every Tuesdays and Thursdays, open for employees only, the hours from 12 to 4 o'clock. That's my report. Thank you.
Thank you, Tim.
Yeah.
Okay, item number 3, the medical staff report. Is there a medical staff report tonight?
There is not.
Thank you. Okay, then item 4, Chief Executive Officer report.
Great, thanks. Again, COVID is still first and foremost, I think, in everybody's activities right now. Our testing center continues. To date, we have tested 1,084 people. We've had 43 positives that have come through the testing site. 21 of those people have come from the valley here. The rest of them, 20 from Bakersfield. We had one from Victorville and one from Colton, who actually tested positive. And we've had 6 patients in-house, by in-house, I mean in our ED, and that have tested positive for COVID as well. We currently have 78 tests pending from the community testing that we do, and in-house we have 3 from the ED that we're waiting for results on, and 5, excuse me, from the SNF. They were just all retested on Monday, so we're still waiting for a couple of them to come back. Our contract with the county goes through August 31st, and we'll assess just prior to that as to whether we want to go for an extension on that. The biggest issue that we're having right now really has been with regards to the turnaround time that it's taking to get the test back. We're seeing test results coming back up to 18, 19 days after they've been drawn. And so that's obviously a big concern, because again, in most cases, the people are no longer infected by the time they find out that they're positive. And I've discussed that with Matt Constantine with the County Board of Health here. And he said it's an issue they're having everywhere, all throughout the county. And the labs are overwhelmed still, but they still believe that it makes good sense to obviously continue to test the public. So they obviously would like us to continue that when we get to that point. The CDPH has been active again. They've kind of now made a decision that they are kind of through their initial hold on all unnecessary issues. And so we've had 2 surveys. We had one early this morning for life safety, and we had a second one this afternoon. That was more of an infection control. We'll wait for those results to come back. I didn't hear anything on there that I thought was too big of an issue at all. Most of them are minor little things that just need correcting. I was pleased to hear that the SNF inspection for infection control, they thought we were doing an excellent job. And so very pleased by that.
Hey, Tim, we had Board of Pharmacy here today too.
We also had the Board of Pharmacy. Thank you.
Sorry about that.
2 minor little things that they had in there as well. We'll wait again for the final report to see if they even make it onto the final report. But again, that survey went really well as well. So strategic planning, we've received approximately 200 surveys back from the community. We still need to hear from more community members. Again, we're planning on the on-site meeting to be held September 3rd and 4th. So we still have some time to pull that together. But again, we really want to urge everybody to get onto the site there, the Survey Monkey. That doesn't take long to get it done, but we really need to get as much community feedback as we can on that. Every survey counts in terms of helping us make better decisions about what services we're going to offer here, how we're going to offer those, communication issues, and how we interact with the community and they interact with us, with our employees, the whole bit. So again, just a lot of stuff in that survey that we really would love to hear more of, a couple of public comment on. Let me think here. We did receive a SHIP grant, which is a small hospital improvement program grant that was for $84,300. That is to be used for COVID. And so our plan at this point is that we're looking at some testing, possible COVID testing equipment to kind of help out. That'll obviously give us much faster turnaround results that will assist us obviously on critical patients that we need an answer on right away before we admit them. So that's in the works. SB 758. Pleased to report tonight that the bill was heard in the Assembly Health Committee yesterday afternoon and was passed without dissenting vote. That bill, as it stands now, again, redefines, the scope of the seismic work that needs to be done, primarily requiring that at least the ER, the ORs, and the recovery rooms must meet seismic requirements for SPC 5 or 4, 3, 4, or 5. Again, then obviously, the question was, does that impact our plans, the 9-phase plan that we came up with? And the answer to that really is no, it doesn't. Primarily because we've got so much other infrastructure that needs to be done. We're dealing with a 50-year-old building with pipes that are rusting, electrical work, HVAC systems that are, failing. So again, the work that's in that plan that was put together and it's on our website literally is the scope of what we need to do here in Kern Valley. In order to make this place habitable. The plan that was approved yesterday in the Health Committee will also push back the date from 2030 to 2037, obviously for meeting that compliance. While that's great and certainly would give us more time, again, some of the work that we've got to do, we've got to get started on. So, but anyway, that's what's going on with 758. I'm pleased to hear it from here. It's going on to the Appropriations Committee. Hopefully, like I said, there'll be a continuing effort to obviously try to get those changes made to the original seismic bill that was put forth years ago. And like I said, it seems to have a fair amount of support at this point. Let me see the plan. We're working with an orthopedic surgeon right now who has actually approached us that wants to come to Kern Valley to begin doing procedures. He's a physician from Bakersfield, a well-known physician, and Dr. Grimes. And so we're working on him to, at this point in time, to understand what his needs are as it relates to equipment and supplies that he uses. And so I know we've had one of the surgical supply companies, Stryker, I believe, was here today, working with our surgery team, trying to understand, what kind of equipment he normally uses, what opportunities there may be for us to borrow or lease equipment or whatever to get some of his cases done. So we're kind of still in the early stages of doing this. He's asked his people to begin pulling his preference cards for, basically it's a card that lists every instrument that he uses, every tool, whatever, that he uses on every single different type of case that he does. And so those are usually on file in the ORs at each hospital they operate at. And so those are being made for us right now so that we get understanding what we can do and what we might not be able to do for him. But he's pretty excited. He did come up here to the hospital with one of his PAs and looked at everything and met with the team and was very impressed. And so we will continue to push forward on that. So I'll keep you apprised of how that's going. The other thing we're working on is, again, all 19 skilled nursing facilities throughout the county received a subpoena for informational purposes with regards to infection control practices that were going on in each of those facilities. We were not the target of this, primarily because we've not had a positive COVID resident in our SNF. And so this was primarily aimed at 2 or 3 of the facilities down in Bakersfield that had major problems. And so, but we have to respond to that. So we've been dealing with, Heidi and I've been dealing with, and Scott has been dealing with the DA on that and pulling all the information together that they've asked for. We were ready to submit that. We spoke to the Heidi spoke to the DA, I guess yesterday or early this morning, and apparently he said, listen, I'm going to be out of town. He says, take till the end of the week. He said, I won't even look at it till next Tuesday. So again, I want to get it out the door. I just want to get it turned over to him. So we're working that out right now. The last thing I've got in my report is I'm pleased to announce that we've hired Grace Abruzzo as our new manager for physical therapy department. As I think reported last month, James Topolo has decided he wanted to relocate back to the East Coast to be closer to family and to some great golf courses back there. And we obviously wish him well. And Grace obviously had worked with us before. She was actually, we've had her here. She was splitting her time between here and down in LA, where she normally works. And she has family here in the Valley who is excited that she's going to be moving here. So she's already gotten started and dug in already and getting started with some things in there. So we're real happy to have her on board. And she received the support of the staff down there very highly. They recommended her. So anyway, and I'll try and get her out to meet with everybody, and so you get to know the new managers as they come through. And that's my report.
Hey Tim, what's the timing on Grace? Is James still here on site?
No, he left last Friday. It was his last day.
Okay, all right.
Matter of fact, yeah, he actually didn't. I didn't learn until just yesterday that he actually left on Thursday. Because I was so swamped with meetings and stuff like this, and issues that had come up that didn't even get a chance to say goodbye to him. And so, but I've got his cell phone number, and we're going to be following up. But we talked several times before he left. I mean, he himself had strongly recommended that we hire Grace.
Good.
As well. So he's gotten everybody's support down there.
Well, that's great. Sounds like that's going to be a smooth transition.
I think so.
I've got a couple questions for you, Tim.
Yeah.
And I'll get to the other board members too if they have any questions or comments on the strategic planning and the surveys. You know, you'd mentioned that we've got these surveys going on. I want to encourage the board members to put that out to your Facebook friends, to your email list, to whoever will listen to you, to encourage residents of the Kern River Valley to participate in that survey. And of course, everybody who's attending this meeting, do the same thing. You know, we've got what, 18,000 residents in the Valley, and you know, we don't want 50 responses. We want hundreds of responses, if not more. So please, all board members, take this on as a personal mission and go forward and see if you can get community participation in this survey. It'd be a really good thing for us. On SB 758, that's great news about it passing the Assembly Health Committee. And we've still got a ways to go. It's got to get past appropriations. If they make any changes to it, it's got to go back to the Senate for approval. It's got to go to the Assembly floor for approval, and then the governor's got to sign it. So it sounds like it's moving in the right direction, but we're not there yet. We still have a long way to go with it. So stay vigilant with it if you would. Because especially in appropriations, things can always go south there.
Yes. Definitely.
Any other board members have questions for Tim?
No.
Okay, seeing none. Thank you, Tim.
You're welcome.
Oh,
Would
wait.
this be the time I could ask you about communications and putting these meetings like it is right now, where we don't have another system? Anything where the entire board is meeting, like planning commission or listening, on the website or the internet somewhere where it can be accessed by the public, whoever wants to see it. Tim, can we do that? In the past, the old ones, it says view and you can't see, you can't pull it up. And what do we do to be able to just post this where people can see it, the public?
It's the board meetings, the videos have been posted from the board meetings. I'm not sure.
They're not viewable.
Yeah. I mean, if there was a technical issue, that would be the only time that that didn't happen. So, I mean, certainly we have the ability, obviously, to do that with these meetings as well. I mean, that's why we kind of open them up to the public anyway, and we certainly do have some public on the call here tonight. So
you're saying we're supposed to be doing it, and the fact we're not doing it is somebody's problem.
I think there's miscommunication here, guys.
Yep.
Gene, you're talking about the Building and Planning Committee, correct?
No, I'm talking about communication, this not being published on the website. So where
They
people
are.
can see this.
They are on the website. They're available to the public.
They're not viewable. You can't. Okay, let me get it straight. You're saying it's supposed to be viewable. You were supposed to be able to look at it. Somebody's just not doing it right.
I don't know. All I know from my experience, when I click on it, I can see it.
Okay, okay. Then if it's not in there, then we can get somebody to do their job. Right, Jim?
I think, again, we need to check into it, Gene, to find out, is this a setting? I don't know if this is happening to you. Is it a setting on your computer or whatever? We'll find out from others as to whether others can see it
It's
as well.
supposed to be posted. Is what
So
you're saying.
let me say something here, because I think this was a member of the public commented on this week or last week. It's my understanding that the question arose after the board had completed a closed session, and before you called the open session to order, that all the board members were together in the room, and that the district may or may not have been filming that, but the request from the public was that any recording that occurred between the closed session and the open session be included as part of the video that the district posts, and not not started with the call to order. And so the member of the public wanted all of the recording from the end of the closed session to the end of the meeting, and not just call to order to end of the meeting. And my comment to that was, that is in the discretion of the board. So the board can post whatever it wants. The board isn't required to post anything, but the board can post whatever it wants. So if you want the recording to start when closed session ends, you can do that. If you want to do it at call to order, you can do that. That is an issue that is in the discretion of the board.
That's not, you're coming in from some totally different. All I asked was, are we from call to order posting it so it can be viewed? Tim, is that the way it's supposed to be?
We are.
Okay, it's the way it's supposed to be. Then if somebody's not doing a job, we can address that.
So can we make this, Gene, would it be appropriate to make this as a formal referral to Tim and have him examine this and report back to the board on his findings?
Yes.
Yeah, he should. You should do it at board member comments. That's what board member comments are supposed to.
Okay. I'll hold what I'm saying until comments.
Okay, thank you guys.
Thank you.
Thanks, Tim.
Okay, then we are there any other board questions or comments to Tim on his report? All right, then we're moving on to the Chief Nursing Officer, Mark. Uh-oh,
Can you hear me?
you froze there for a second.
Oh, sorry.
Now we can.
All right. Is that a live picture behind you?
No, it's a virtual. It's a snapshot from earlier.
Oh. Yeah, that's horrible what's going on over in Haviland and stuff. I got a few nurses that live over there. So I want to start out by talking about the CNA program that just finished. It's been very successful. I do want to acknowledge the instructor, Donna Bianco. Our DON over there received, Sally Markman, she received a call from the clinical site examination person. Her name is Belinda, and I want to read some of the excerpts from that call. She says that Sally says, I received a call from Belinda at the testing site in Los Angeles requesting to talk to Donna Bianco. I asked her if there was anything I could help her with. And again, this is Sally talking. And did she need to talk to the administrator? She proceeded to tell me that how professional the students are, how they professionally conducted themselves, how well they did. She had never had any students like this set before. She's never called an instructor for this kind of accolade. She was very excited and really wanted Donna to know how well she did. So Sally did take her number down and wanted Donna to call her back. But for a for a clinical site instructor from Los Angeles to call and let an instructor know how good, how well, and how professional her students were is really a big deal. So I just wanted to make that known to the board so you guys have that to think about. The next thing I wanted to, and plus we're getting ready to start our next program in September, the first week in September. So we're gonna have from anywhere from 8 to 10 students, however many apply and get through the interview process. So we're excited for that. We're really looking forward to being able to get this program moving forward. So anyway, of the 8 original students that started out in the first program, 5 of them graduated and then went on to actually pass and receive their clinical skills certification for CNA. Of the other 3, one of them went to another job, one of them moved out of the state, and one of them had a problem with her sister. She had to go take care of her sister, so she had to drop out. So there were no failures as far as academically. It was just more of a logistical, demographical thing. So on the next thing, the data that I report to the county or to the state continues to evolve. The latest iteration was 35 elements that are being reported to the state as far as COVID numbers for us. Now there's a lot of zeros on our page as far as how many COVID patients we've had in, today and what age groups and all that stuff. But it seems like that document evolves frequently. And so Tim and I are very aware of what's happening. He was on a CEO call earlier. Don't know if there was anything that came out of that, but we are going to continue to report the numbers to the best of our ability. And, we'll just take it from there one step at a time and one day at a time. So the emergency procedures for pre-screening remain in place. However, I did do a few modifications to it. I chose to allow lab and dietary and maintenance to start keeping their own logs. So when a person comes into dietary, they will be pre-screened at the door before they go into the room, but they don't have to go to the pre-screening site where other triage patients are and things like that. So I've kind of been able to decrease some of the congestion at the pre-screening area where triages are taking place for the ER. ER numbers seem to be returning, hopefully. We had an average of 17.8 patients in July, which is up from some abysmal numbers the month prior. And August is trending around 18 a day so far. So we're hopeful that those numbers are coming back. We do happen to see a lot of patients now that are not related to COVID patients. They're not shortness of breath, they're not coughs, they're other kinds of things. So we're happy to see that people are not afraid to come to the ER for their ailments anymore. And then the final thing I have to talk about is the HCAP scores. They're improving. I'll be focusing my efforts with the staff to continue to provide compassionate and always meet your needs kind of care. I did have a conference. I'm sorry.
Could you refresh our memory on what HCAP means?
Somebody was going to ask that, weren't they? These are the patient satisfaction scores, and I don't have the acronym right in front of me, but it's the I forget what it is, but
I just need to understand the context.
It has to deal with patient satisfaction and customer satisfaction surveys.
Thank you.
And we have that done by an outside source from Illinois Critical Access Hospital Network. We've been very successful. We get about 25 to 30% return on all the satisfaction surveys that go out, which is probably industry standard. For industry, it's pretty good return. Dr. Finstad has been very impressed with the return with those satisfaction surveys. So getting back to what I was talking about, I did have some information from the Studer group which is a group that is out there that helps facilities improve their satisfaction survey scores. They do many other things, but I had a call with them on July 7th and then again on July 13th. The only trouble that I'm having with the Studer group is how expensive they are. They're very good at, they had a very well constructed demonstration with offerings on how to spend our money, it seemed to me. Our satisfaction surveys are not, they're not, CMS doesn't use our satisfaction scores to pay us like they do other facilities. We like to have the numbers, the scores for the star ratings and things like that, and our numbers are improving all the time. Nursing staff meetings are the vehicles where I present my 5-part series that I've been working on to get nurses communication and doctor communication down. So I've come up with this 5-part series and tried to do it without spending, you know, a lot of money on it. So we're seeing some improvements in those scores, and we're happy to see that. We are a 3-star facility in Kern County, which is one of 2 3-star facilities, I think, Tim, if you could help me out with that. So anyway, that's my report. If there are any questions, feel free.
Thank you, Mark. Board members, are there any questions of Mark?
No. I have one. Mark, I've been dealing with, I understand that there's a new term for CNA, PTT, is the patient care technicians. You still have to be, is it the same level of certification as a CNA?
I've never had that term. I've never heard that PCT term.
Yeah, I've heard of it. It's actually it's an additional certification they have to go for. It is different than a regular CNA.
All right. I've been dealing with it here. I've spoken to the staff here at Kern Medical, and you know, they don't have any CNAs. They'll have the charge nurse, and then they'll have a PCT with them, and that's the patient care technician. We talked about it a little bit.
You know, many years ago, Charlie, many years ago, there was a push to get a super CNA, and the California Nurses Association kind of put the kibosh on that because they were being asked to insert Foley catheters and do a lot of the things that the RNs and the LVNs do. And so the RN union decided they didn't want to see anybody taking our jobs. So it was kind of interesting, and that was quelled or kiboshed. This PCT, I don't know what it consists of, but I will get some answers for you to find out.
I just thought I'd bring it up. Thanks.
Sure.
Okay, any other questions of the board members? All right, Mark, thank you. Thanks for that report. And maybe Debbie Hess, if you're still around, maybe hey Debbie, consider doing an article on the CNA instructor. That's pretty amazing. Kudos from the LA area. Just a thought.
She'll come up with a story with, she'll get with Mark and put something out.
Right.
Some kind of press release or something to the sun.
Super. When we do good stuff like that, we need to be harping on it. Make sure the public understands what's going on in that facility. So, thank you.
Can I go ahead and say something else?
Yeah.
Earlier when Tim was talking about the orthopedic surgeon, I've got some preliminary survey results that I sent out to my team today. And Charlie, I have yours, so I'll have to send it to you tomorrow. Anyway, the orthopedic surgeon, that came out at 79% people would like to see something like that up here. So I just wanted to let you know.
That's terrific. Thank you. That's really good news. Well, that's going to be a good match, guys.
Thank you.
Okay. we're going to move on to the Chief Financial Officer report, but following that report, we had several members of the public join the meeting after we got past the public comment portion on the agenda. And so I'd like to revisit that after Chet's report and see if there are any public comments before we move on to old business. So Chet, it's up to you.
Hey, point of order, please. Can you,
Yes, John.
okay, can you do that? Because it'll be amending the agenda, which has already been approved.
Well, that's a good question. I don't know if I have the authority to do that.
Yeah, it's fine.
Okay.
Is that okay? All right, thank you.
Yeah.
Thanks, John. Okay, Chet, take it away.
Okay. Tonight we'll talk a little bit about the month of June and the fiscal year of 2020. We'll start by talking about volumes, and we'll address first the medical surgical area. In the medical surgical area, we actually had approximately 20 admissions for the month of June. A year ago before that, for the same month, we had 46 admissions, so that was less than half the admissions. Interestingly, in the patient days, we didn't see that large of a decline. Actually, we had 150 patient days in the medical surgical area. Again, this includes acute and swing beds. In the prior year, for the same month, we had 168. Now, that type of difference between the patient days and the admissions actually provides a length of stay that wouldn't normally have a concern if it was for a whole year, but for 1 month, it does not. As you know, for critical access hospital, probably know, for a critical access hospital, you must have a length of stay for your fiscal year for your medical surgical services that's under 4 days. That the month of June, actually for acute, I'm talking about for acute patients, under 4 days. For the acute patients, that actually meant 4.9 day length of stay, which would have exceeded the maximum allowable for a critical access hospital. A year ago, before that, for acute, we had a 2.8 day length of stay. So they're keeping some patients in acute beds longer than what they should. We just need to get back to the level, and I'm sure that probably the coronavirus pandemic has impacted that to some degree, trying to ensure that those patients are meet the clinical criteria for a different level than acute, and also the fact that we have been housing some patients who need quarantine before they go into the SNF in swing beds, which I think is a very positive move clinically and also business-wise for the hospital. One of the things that is not too much of a problem, I don't think, even though what that does is bring the patient days for the full year of fiscal 2020 to 4.5, which is again above the maximum allowable. That may come back and give us a problem, but I think with the coronavirus waivers, it will be a part of the waiver, and I don't believe that I foresee at this particular point in time a huge problem. The year prior to that particular level of acute was a 3.5, so obviously it did not present a problem. 3.5, if we get back to the 3.5 kind of length of stay for acute, will be where we probably should be as a norm. For the swing beds, we actually got to for the month of June, we got to a 30.5 day length of stay. That normally is a little high in swing beds, but again, in the prior year, which had no COVID type patients, we were at 44 days. So effectively, it didn't change dramatically for that particular month. For the year to date, however, we were at 23.4 days for the entire year in swing bed patient days, and the prior year was at 12.2. 12.2 is again about where it should be. Placing COVID screening patients or quarantine patients in those beds for 14-day quarantine in this particular case drives that up. Again, I think it would be a factor of labor, and I don't think really there's not a specific item for swing beds, and they don't recognize swing beds length of stay in the regulations. But the situation is, it is pushing again against the upper limits, and we should, over time, as the COVID winds down, if it does, get back to the length of stay of less than 15. Our average daily census then was at 3 days for acute and in the acute beds versus 4.1 in the prior year, and 3.6 for the entire year versus the prior year at 4.8. Our length of stay in swing beds was 2.0 versus 1.5 for the month of June, and for the entire fiscal year of 2020, it was a 2.7 versus 0.7. Certainly the 2.7 is more appropriate. There's a small amount in there that relates to COVID, but over time, we should be seeing over 2 patients or right at 2 patients average daily census in swing beds. When you go to the long-term care, which should not be affected dramatically by the COVID, except for the patients waiting for the quarantine in the swing beds, we were actually at 53.7 days, or 7 residents per day, and in the prior year, we were at 58.1. So you can see we were down some. Even if we factored in quarantine patients, that certainly would be a reduction still. We may gain one patient per day, maybe in that at the most. For the entire year, we were at 54.9 patient average residents per day in the SNF versus a 56.3 in the prior fiscal year. Our emergency room, as Mark says, it's coming up a little bit from what it has been. It still was only around 17 average patients per day. We did 498 visits. Our visits in the prior year were 643. What I try to use as kind of the criteria is we'd like to see about 600 patients a month, or an average daily census visits in the ER of about 20. We are not there, and we are not there in the month of July, and we are not there in the month of August today, although we've had a couple of good days. So we were actually at 6,823 visits for the fiscal year of 2020. 2019 was at 7,229, which show for the year us being down from what we had. Referred outpatients, we were almost up to the prior year. We had 1,012, which is better than it has been, versus 1,027 in June of 2019. For the total fiscal year, we went 11,704 versus 13,130 in the prior fiscal year. So we have suffered a little bit on some of our ancillary service. Certainly the rehab services reduction, which were a good share of our outpatient referred patients, were 100% directly proportional to COVID for the most part. We actually had clinic visits higher than the prior year, so we were still seeing patients in our clinic. We had 1,482 primary care clinic visits and 278 specialty visits, mostly mental health, plus some other specialties. The prior year, for the month of June, we had 1,278 primary care and 349, a little bit higher in the specialty area. For the year, we actually had 16,813 primary care visits in the clinic, and the prior year we had 15,475, 15,475, and in the specialty area, this particular fiscal year we had 3,421, about 3,480 in the prior fiscal year. So specialty visits were pretty close. We gained substantially in the primary care, and this is still including all the COVID months. So the clinic has really been keeping it up, and the patients still seem to be willing and ready to go to the clinic, regardless of the COVID and what it brings to the table. The surgeries are non-existent for basically this year. The prior year, they only just non-endoscopies, surgeries only. They had 2. They were inpatient only. 4th fiscal year, 5 this year, 7 in the prior year for inpatient, outpatient, 28 this fiscal year, 40 in the prior fiscal year, non-endoscopies, so simply outpatient surgeries. So we are certainly still filling something there. We did have the months. Some of that outpatient obviously is a function of COVID, proportionally again, because we had to close the unit for basically close to 3 months. The endoscopies, basically, we didn't have much in some of the months, also because we had that shut down. But in the month of June, we actually had more back operating. We had actually more than we had in the prior June fiscal year at 41. Prior June fiscal year was at 36. Year to date, for 12 months, 2020, 390 scopes out, endoscopies versus outpatient versus 489 in the prior year. Our pharmacy scripts we're almost fairly close to what they were in June of the prior year. Matter of fact, only 1 script different. 368 scripts filled, 3,368 scripts filled, 2,367 scripts filled in the prior year June. For the entire fiscal year, we had a good growth in our prescription filled in the retail pharmacy, 41,735 versus the prior fiscal year, 37,912. For the month of June, in dollars of gross patient revenue generation, we had $8.5 million, 8.529 of revenue generated. In the prior year, June, 9,245,000. So we had close to $1 million again in reductions from gross revenue generated. That happened in all product lines, with the exception of the retail pharmacy, which was 14,000 ahead of the budget. So basically, all of the other product lines, including inpatient, clinic, outpatient, referred, and long-term care, had less revenue than they did in the prior year. The next part is contractual allowance. A little different in the month of June, because in the month of June is when we had a significant amount, May and June, significant amount of money come in from stimulus money and other sources like Prime. Like also we even had a little bit of I believe property taxes come through. I'll have to double check that. But basically, we had a significant amount of money come through, and we worked very hard because we had the reductions in volume and we kept our expenses up. So we had, and our contractual allowances had stayed relatively flat. So we put as much money that we knew we weren't going to have to pay back. The money we were going to have to pay back at that particular time, we did not put into the income statement, but we put the rest into the income statement. So our contractual allowance actually went down from what we would normally have seen. So we would normally think with a 9 million, a little over $9 million we'd see about $7 million in contractual allowances and bad debts. We only saw 5.7 million, and for 9.2 last year we saw 6.3. So effectively, we had, for the generation of net revenue, net collectible revenue, instead of being under like we were for the gross by $1 million, we're actually over there because we put money from stimulus money, et cetera, into the bottom line. We gained $318,000 positive over our budget for the contractual amount, for the contractual allowances and bad debts. So our budget was to generate about for the month was generate about 2.5 million in collectible revenue. We generated 2.8 in the prior year, even with the higher amount, $9.2 million in gross revenue. We generated 2.9 million in collectibles. So we were almost that much, even with lesser revenue, because of what we made up from the stimulus money. One of the things that actually also happened is our salaries, our expenses, our direct expenses. Our direct expenses actually were $72,000 higher than our budget. Our budget was $2,489,000. We were at $2,416,000. In the prior year, we were at $2,223,000. Our big differences basically were in benefits. One of the things there in benefits is where we actually had let employees take benefits like PTO because their children were home from school, and so we used contract labor. On the other hand, our contract labor total values were not dramatically less than what they were in the prior year, but they were less than what we had anticipated in our budget. So some of that negative in the benefit structure was offset by a positive in the contractual that we thought would, or in the contracts that we thought would be there, 42 versus 26. The rest of it was a direct hit to the bottom line for allowing people to take off and use contract labor. The physician's fees, because the volume was down, was at less than what we had last year, but because of the income guarantees for highest paid physicians, meaning the hospitalist group, they get paid anyway, no matter whether they have the patients. We don't have the patients, so we didn't gain in that. We did do well in the purchase service area. We have budgeted effectively more than what we did have, but the budget was substantially higher than what we had actually had in the prior year. So we were still higher than the prior year, but not effectively higher than the budget. The supplies, again, were pretty good size over. As a matter of fact, that was $28,000. All of that was pharmaceuticals. We continue to see, although we're up a little bit above budget in the volume and the filled prescriptions, we continue to have even a greater overage of that in the pharmaceuticals that we are buying. Utilities actually was down a little bit under the budget, down a little bit under the prior year, which it should be because of the energy conservation
system that we have put in. That's what we anticipated, was to have things a little less. Repairs and maintenance, we put extra money in at this particular fiscal year. So we do more in-house. We didn't spend nearly as much in-house as we had anticipated. So it was a situation where that was a positive for us, although we are not sure that we're getting everything done that we need. The insurance expense was a little higher and a little higher than budget. And we knew once we got information from the insurance company that we were going to see double-digit inflationary factors because of losses to the industry. Other than that, we were really pretty well along. And so for the surplus, the operating surplus, we actually, because of the money we put in from the stimulus money into 1 month, rather than having it spread out, we've actually had an operating profit of $428,000. The budget for the operating profit was 44. The prior year, that we had a very good June, because we tried to put money in the June at the end of the year, put that non-operating that can go to the bottom line. We had a $692,000 operating profit. We got through past the non-operating. We actually had $422,000 profit in the month of June. $49,000 was our budget. $700,000 in the year before. But again, at the end of the prior year, putting the money in there, having stimulus money is what created that $422,000. We go down to the year to date. It still keeps us at a loss for the year. A loss for the year is still $576,000. The budget was to make $633 profit. The prior year we made $437 profit. So our cost, of what I can say is our cost non-reimbursed for the year at this point, because of the reductions in volume from COVID, is a loss of about $575,000. That's net of money coming from the government to help make us whole. To me, that really, for the nature of COVID and what it meant to a lot of hospitals in the millions, $576,000 loss, it really isn't too bad. And that's that part. I'm now going to go down to the budget comparison with cash. With cash for
Hey, Chet, can I stop you for a sec?
Sure.
On the agenda packet, page 23, is that executive financial summary. It's got all the colored charts and whatnot on it.
Yeah.
The financial strength index. When I was appointed to the board last May, so a little over a year ago, that financial strength index was a negative 4.32, and which was in the poor category. And, you know, I would venture to say very poor.
Right.
And it is now a 1.64, negative 1.64.
Right.
Which is actually in the fair category. And I just wanted to point that out, that, you know, that's something that I look at every month at the report, and it's always getting better. And I think that's a really good indicator of what's going on with the district.
It is a good indicator. I agree with that 100%. Because it builds on a different, it's not just one thing, it's not just the profitability, it's the mix of your operations. Yes, I agree with that.
We're definitely going in the right direction, so thank you. And I don't know how much longer you got, but if you can kind of summarize and move it along, that'd be great.
I can do that, and I'll jump through it real fast. We started out actually a little less than what I had anticipated for operations, because the money we moved into the LAIF and into the reserves. We started out with 102 versus what I had projected originally in the budget of 434. But we also got, as I said, extra money in, not quite as much as we got in May, but we got extra money in. So we took in 3.2 million versus 2.0, which I had forecasted.
The cash disbursements were up by about $400,000, 2.6 versus 2 point, not quite 2.2, 2.16 that I had forecasted. No money was put out to go out to non-operating except for $3,708, which was the interest on the line of credit. I had thought money would come in from that. So we got down to the cash before reserves in the local bank for operations. We were at 764 versus my budget for the beginning of last year, 592. We had 144,000 in operating reserve, which matched the budget. The Medicare overpayment, we had put some money in there. I said it wasn't going to be hardly anything, $8,000. We put $1 million there of this extra money we had that we didn't put into non-operating reserve. So we have an extra $1 million in operating reserves. So we ended up with the cash balance for operations of right at $2 million, 1.983 versus what I said was 655. If that's not.
Okay, have you concluded?
Yes.
All right, Chad, thank you. So we had several members of the public join the meeting, and I'd like to give you the opportunity to address the board on any matter not on this agenda over which we have jurisdiction. And Heidi, I think everybody is muted. Is that something you can control? Can you unmute everybody so that they can speak up if they want to be heard? And okay, so just unmute yourself. Okay, thank you. I just want to make sure there wasn't a system thing that they had to overcome.
I cannot believe so.
Thank you. Okay, then the way this will work, if you want to be heard, if you have an issue that you want to address to the board, I've got 3 minutes, and state your name, unmute yourself, and begin to speak, and we'll figure out who goes first once we get started. Jim Dietzel had sent a note on chat earlier. Jim, do you want to go first? He's still muted. So to unmute yourself, you can either click on, a little blue box at the top of your screen to unmute yourself, or you can hold the space bar down as if you're speaking into a microphone, and hold the space bar down as like cueing the mic. Okay, so I can see on the screen, Jim, that you are unmuted, but we can't hear anything yet. Okay, he's just sent me a note saying his mic's not working, so okay. Gary or Catherine, or do either of you wish to speak to the board?
I don't have any questions.
Thank you, Catherine. Gary, do you want to speak?
Nothing here.
Thank you, sir. Okay, and we'll move on in our agenda. Sorry for the technical issues and the whole COVID thing. That it makes conducting meeting in public a little more difficult. So Jim, continue to send me notes and we'll get this figured out. Okay, so old business. I don't have anything listed under old business. Tim, did you have any that you want to discuss?
No, I don't.
Any board members? Okay. Then that brings us to new business, and the first item is capital expenditure. The penetration test. This is a software tested to judge our vulnerability against intruders. So, Carrie, are you there?
I am. So this is a capital expenditure request for penetration testing, like you said. So what this does is provide external testing for our IPs, where an outside source comes in and tries to exploit any vulnerabilities that are within our system. And then a team of individuals comes in and tries to take those exploit those vulnerabilities that have been noticed and actually tries to get in through them. So we're looking for TrueBridge to do this. They provide the scan as well as 4 additional scans throughout the year, so that as we patch, they can come back in and try to make sure that that patch was successful on our end. This was a recommendation through our 2019 risk assessment. And so this is trying to get us in compliance with what that assessment pointed out as a vulnerability.
Okay, and what did the finance committee do with this? Where's the finance committee on this? Are they recommending approval?
Yes, we're definitely recommending it. If I need to make a motion, I'll make it, and we approve the request.
So I have questions on it. So we had two bids, it looks like. One from TrueBridge for $12,600 and one from Secure Works for 1,000 less, basically 11,600. And just wonder what the rationale is for going with the higher bidder.
2 reasons. Number one is that there are SHIP grant funds that are going to be funding $11,800 of this request, and in not using all of the money we would be leaving $200 on the table. The second is that there's more bang for the buck with the TrueBridge thing, whereas the SecureWorks one does not provide the additional scans. So they would provide their initial report and allow us to know what exploits are out there, what vulnerabilities are out there. But then as we patched or think we patched, we would not be able to have those additional scans to prove that our patch was successful. So TrueBridge is providing those additional scans, which are very valuable to know that whatever remedies we put in place are actually successful.
Okay. So after this test, and if weaknesses are discovered, then I'm assuming there's going to be additional costs to fix those weaknesses.
No, these would be done internally.
It's well, I couldn't hear you.
It would be done internally with our staff, IT staff, to fix the vulnerabilities.
I see. Okay, so it's something that we'll be able to fix internally?
I believe so, yeah. We don't have the report yet.
Right. Yeah, we don't know what the vulnerabilities are.
But in past, we have had one scan that was provided to us by TrueBridge that pointed out a number of vulnerabilities. I forget how many pages, upwards of 30 pages of vulnerabilities. And we were able to patch probably 50 to 60% of those with simple software upgrades. So that was a no cost to the hospital to fix those and dramatically decreased our vulnerability.
So the only thing that's given me heartburn or raising a red flag with me is you've got one vendor hired, conceivably hired to tell you what's wrong with your system, and then we want to rely on that vendor to help us fix that system. And it seems inherent in that kind of relationship that they're going to find things, whether they're really wrong or not, and then charge us to fix them down the road.
They will not be used to help fix the system. They're only going to be used to point out the vulnerabilities.
Okay. All right. That helps. Thank you. So are we already in compliance with like HIPAA standards and other privacy standards? This test, I just wonder, is it above and beyond what we need to be doing? Or are we already meeting privacy standards and protecting patient information?
Ross's system, it's one of a number of things, obviously, that the hospital has to do to meet HIPAA requirements. You know, obviously, one of the things that has been put out there from the federal legislation perspective is that obviously they want us going back and testing our systems to make sure that we don't have holes in our system that allow people to get in and get onto a patient's information or other sensitive information that people aren't supposed to have. So that's really what we're trying to do here. There's a whole series of things we did.
All right.
We did a risk vulnerability study about a year or so ago. That was our first start in that, and that yielded, that was a huge report that came off of there. And the staff here at the hospital have been working on that for quite some time, and we've gotten most of those taken care of. One of the big ones that we have left is obviously this one here, to make sure that we have an outside company test this to see if they can get into our systems and get at data. So this is a kind of a critical thing for us, just to make sure that we've looked at everything that we can get our hands on. So
Thanks, Tim.
obviously fix that as best we can.
I want to add too that there were risk categories to each of these items that were pointed out during our risk assessment, and this was one of the items that was in the high risk category that we have not been doing for these vulnerability scans.
Thank you, Carrie. Okay, so Jean made a motion to approve this agreement or this purchase. Is there a second?
I'll second it.
You can't, is that Jean?
Yeah.
You can't do that, buddy.
I'll second.
John, thank you. Is there any more discussion among the board?
It looks like you may have a question from the public on Zoom on chat, as long as they can, if they can identify themselves in the comment section. I don't know if it is about the CER, but if that is the case, they can ask a question over.
Okay, it looks like a question from Jim Dietzel, being funny. How does a deaf guy ask a question in the meeting? So I'm looking at your chat. What's your question, Jim? We'll give him a couple minutes to type his response. John, thank you for pointing that out.
I saw that he put it up while Carrie was talking, so I'm assuming it was about the CEO.
Okay. I find it difficult to listen to the reports and follow the agenda and read the chat at the same time. So thanks. I'm glad you pointed it out. Okay, it looks like these comments aren't related to this contract, so I'll get back to those in just a second. So we have a motion and a second. Any discussion? All right, seeing none, then John, your vote.
Yes.
Jean, your vote.
Yes.
Barbara, your vote.
Yes.
Charlie, are you still with us?
I am, yes.
All right, and I will vote yes also. Okay, so this item is approved. The things that Jim Dietzel is asking are related to, let's see, I have a question below. It is possible that fund could be set up by the hospital or foundation dedicated solely to the funding seismic retrofit. So basically an alternate funding source for building construction. And if there are any HR issues precipitated by the fiscal year 21 goal, I'm not sure.
I think what he's referencing there, Ross, is the goal that talked about the reducing employee-related claims against the district. And the issue here was that in prior year, we had a couple of actions with some of the employees and so forth that resulted in potential lawsuits or legal issues that we had to follow up on. And primarily because certain processes or policies weren't followed the way they should have been. And so this was really an effort to go back and make sure that each of the managers are following that process with regards to discipline and other things like that. Just to obviously cut that exposure and reduce that expense, because that's a controllable expense. That's what that was for.
Yes. Thank you, Tim. Yeah, this would be so much easier if we could actually have a conversation. But Jim, we've got your issues here. They're recorded in the chat log. So if Tim, can we bring these not the HR goal one, but the funding of the seismic retrofit? Can we discuss that in the Building and Planning Committee meeting? Can I make this a referral to that committee for examination?
It's actually almost a foundation issue. I mean, if the foundation wants to create a fund that people could donate to, that could be applied towards the seismic work that we do.
Okay.
That might be a place to send that.
Can we make a referral to the foundation, or a completely separate entity?
We can certainly request that they do so.
Okay, so we can let them know about this idea, and within their realm, they can decide whether to pursue that or not, correct?
Correct.
Okay. Can you put those pieces together?
Absolutely. Deb's in my office right now, so
Okay.
make sure she follows through on that. So.
All right. Thank you. Okay, so the next item on our agenda
Budgeted cash flow.
Okay, that's mine. The situation basically there, so I'll get through this very quickly. Again, the budgeted cash flow is cash flow for operations. It's to show how we're going to get through our operations and pay for it in fiscal year 2021. As you can see at the top, we start for operations with 170, 416. Probably based upon what I just told you about the month of June, it'll be a little higher than that because I did this in May. So we'll have a little more than that to start. If you go over to, we go up and down, basically as was iterated in my budget assumptions that were approved by the board. The cash receipts are a function of the cash receipts for this fiscal year, less any stimulus money items that are a one-time thing with no inflationary increase or higher percentage payment increase, even though we raised the prices by 7%. We should get a portion of that, but I don't put that into an operational cash flow budget. Then you come down to the expenses. The expenses are actually based upon the actual cash flow, cash disbursement expenses that we had in fiscal year 2020, plus an inflation factor that was also in the budget assumptions, which the board approved, meaning 4% for salaries, 3.5% for supplies and pharmaceuticals, 5% for utilities, etc., some purchase services. Then we have the non-operational items, which actually are talking about, for the most part, what you can see there is the IGT funding. This is where we have to fund our portion of what IGT pays. You can see there that I'm saying that's going to cost us about $3.4 million. How do we get that? Basically, at the time, you can see we borrowed from the LAIF. We actually brought out $3.5 million, and the money comes back through up above in the IGT up in the first section. It also has us paying bond principal and interest. So I should say half of the bond principal and 100% of the interest at $790,000, and it only has at this point and about $25,000 on the line of credit, which actually we only have $50,000 left on the line, so that would pay that half off unless we borrowed more. Then that brings us to that part. Then we have the operating reserve of 144, which is what we actually have at the end of June. We have the Medicare overpayment, which money we put in there. Remember, I said we put about 1.7 million into that reserve. We take that down, we borrow out some of it actually in the month of August. We haven't had to do that yet. That may not have to happen, but it did at the time that I did this. We end up about 773 there. So we end up with, for operations, a net remaining of 334,248, which was up from the beginning balance of 170,416 at the beginning of the year. And that's the cash flow budget for operations.
Thank you, Chet. So when is the appropriate time to take some of these big chunks of revenue that we're getting, like the IGT and some of the stimulus money and whatnot, and put that in reserves for our construction project?
As you get it, usually you do that on a cash basis, because the whole idea is how much can you put into you can take it back out of the reserves if you want to, but we put most of it already into the reserves at this point in time.
Okay, so it's already in reserve. It's in reserve, but we haven't designated
It's already been moved to LAIF.
What's that?
It's already been moved to the LAIF account. I would, if you want to go back and look at that through June, let me just bring up the balance sheet there. Come back up here. There's a line on the balance sheet that will help you kind of see that. And it's under, I actually put it into restricted, although not all of it has been board designated to restricted, only a portion of it has. The board has to do that formally with the resolution. So if you go back up to, find the page number here. I think the only balance sheet item, I don't think we have a detailed balance sheet here. We only have the summary. There's a line item on the balance sheet, the detail in the financial packet, and it's called investments. That has gone from the end of the prior, if you were to look at June, you would see the end of the prior year at about 3.5 million, 3.5, I believe is what it is. You would see the balance at the end of June this year of $9 million. So monies have been funneled in there from that. It's a situation where we take out about 3.5 million out of that to pay our portion of the matching. When it comes in, we put money back in there, and then we put money that we think we can over on top of that. So as of today, right now, in this moment, we have $9 million in the LAIF account. It's about 4 million of it that the board has designated for construction. And we have $1 million in the, as I showed you just a little while ago, in what we call the Medicare reserve that I put into operations. It's not in the long term or the other reserves outside. It is in operations.
Okay, so be thinking then, I don't expect you to answer this tonight, and I don't think we need that action by the board tonight, but at the appropriate time, come back with a recommendation on when this should be held in reserve for our construction project. Because there are a lot of demands on the hospital, a lot of demands, a lot of things that we need, and if we're going to try and improve this hospital with the resources we have, we need to set this money aside to do that. So
let me say
to you to
a little bit to help in your thought process that the budget that you basically approved, the summary budget, operationally in the income statement, had $1 million of an additional cost for COVID that we put into that and the board approved. I would say if we have the $9 million in the LAIF, if the board was going to do something
other than the $4 million that has been board designated for construction, I would actually request of you that you take $1 million and you approve that as board designated for COVID related costs, so that it could only be used for that until the board designates something different. The remaining, that would then take us up to $5 million out of the $9 million. The other $4 million you could leave undesignated, or you could designate it for whatever as you deem appropriate with the resolution.
Well, I'll let you guys hash it out on the finance committee. I just wanted to make sure we were kind of heading in that direction.
The PPP 2 million, is that part of the 9?
The PPP is part of the 9.
Okay, well, it's not ours until it's forgiven.
It is not, at this point in time, it's still owed, even though we have it over in the late so it can earn the money. Okay, so until such time as the bank that loaned us the money is satisfied that it meets all the criteria, then it can be considered as a grant and not a loan. But at this point, we're not there yet.
But we're not there yet. Okay.
We're really talking, what they did is originally they had it at 8 weeks. It's now 24 weeks. I do not expect the banks to do anything until close to that 24-week threshold. And then we'll see something from them in that regard. The biggest thing we have right now is in that money, in that $4 million also, we got an advance of $2.6 million in Medicare money, 6 months of inpatient of hospital, and 3 months of clinic. That actually is definitely a loan. It will have to be paid back unless something in this Congress does something different, which they could. I'm not saying they won't. But basically, the way that starts, actually, we're scheduled to start having a withhold next week. It would start, and they would withhold 100% of our Medicare money with no interest until they recouped the entire $2.6 million. But we have 2 years. If we didn't have, if the full amount wasn't recouped at that, when they recouped the Medicare money in 2 years, then if they start charging interest at 10.5%. There is a movement to get that interest rate down. That's what's by statute from CMS. That's not approved yet. There is a movement to have it waived.
Hey, Chet.
Thought process, we will not get to do that. Yes.
Thank you. Thanks for that report. You guys can hammer out the details in finance committee. And thanks, Gene. I'm glad you're there.
Okay.
And then Charlie. Okay. I need a motion to approve the projected cash flow as recommended by Chet.
I'll make the motion.
A second.
We have a motion and a second. Any more discussion? Okay. Director Blythe, your vote?
Yes.
Director Parks?
Yes.
Director Casas?
Yes.
Director Bush?
Afraid I may have missed too much, but I'm going to abstain.
I couldn't understand what Charlie said.
He didn't hear it, so he abstained.
Yeah. It was difficult
Did he have to?
understand exactly what was being said.
Okay. So abstain, is that correct?
Yes.
Okay. And then I will vote yes. This matter is approved. The next item on the agenda is the employee pension contributions.
That's
And-
me, Dan. What this is, every 6 months, usually in February and July or August, I bring a listing, no names, but the amounts that employees have contributed to the pension plan for the 6-month period prior. In this case, it is January 1st, 2020 through June 30th, 2020. So basically, during that period of time, if the employees that contributed $293,850. Their salaries in total were $3,555,000. So they contributed 8.27% of their salaries into the pension plan. Some contributed more, some contributed less. The finance department is bringing forward a recommendation that the board approve a matching of up to 4% per employee of their salaries if they contributed to max the contribution dollar for dollar, if they contributed into the pension plan. Now, not all employees put in 4%, some of them put less, some of them put more. The ones that put less, we will match only up to whatever they put in, dollar for dollar. So instead of costing the district 4%, which would be if everybody contributed at least 4% or more, we actually have to we would put in 3.64% because we're only matching up to what they put in. That would be, for that 6-month period, $129,554.04. We're proposing that we fund it every pay period, so there's ongoing funding for the employees' accounts, not waiting for the end of the plan year or 8 months after the end of the plan year, which the IRS allows us to have, but funding it as we go along at about $10,000 a pay period. And that's what this recommendation is.
Thank you, Chet. Any questions?
Yes.
Gene?
Can you make 4% with a maximum of say 3,000? Can you put a maximum? My reason for that is, for example, Tim, I always use him as an example. That's 14,000 money.
The answer is not. The board can't put a dollar value. It needs to put a percentage according to the plan. That's what the plan requires. The employee, however, when they put theirs in, can either do it on a percentage basis or on a dollar basis.
My question, Chip, and I wish you would verify. Can we do 4% with a maximum of a certain amount?
No, because you can't have a dollar amount. The plan does not allow for that. You would have to change your whole pension plan to do that.
Okay, because most of it is going to people that's making more money. So the lower end.
Well, even a person, let's say I'm an employee, I make good money, and I want to get the IRS benefit. So I put in 8%. Some do that. I would still only get up to 4% match. That's it, caps right there of my pay.
Yeah,
and that's for everybody.
We want to take care of employees, but my thoughts are we want to help the people that have lower income.
You can't differentiate by employee. Yeah, you can't differentiate by the job. You can't do that. The IRS wouldn't even let you do that.
Okay, that was my question. Is it legal? Can you do that?
No.
You're sure?
I'm positive.
Okay. Then I would rather see us do 2%.
That's at the board discretion.
Okay.
The way the plan is written, some plans are not written that way.
Okay, all right. Hold on, Chet. This is Gene's time to talk. So
we can't afford. Okay, we can't afford that, but the 2% would be, what's the average? I think the average for big corporations, everybody is a little over 2%.
That's correct.
And so we need the money. We can't afford it. And if it were 2%, it would still benefit the lower paid employees. And
I will tell you that when I came, they put this plan into place. The board at that time put this plan into place in 1998. Okay, up until 2001, which is basically when I came, they had not funded it with anything. They said zero because they were in loss position for the year. In 2001, we made some money. I made a recommendation to the board at that time, and that was the first time they funded it. Then actually we funded it until 2007, I believe, when we got into some problems with the SNF. And so during that time, the same thing. They said they would not fund it for a couple of years. Then we got back, and I think since 2009, we funded it every 6 months from then on until now, like clockwork. Originally, in 2001, we were doing, because there were so few, we were only doing about $6,000 a pay period in money that was being contributed by employees because they weren't getting any matching.
Right.
Okay, so at that time we started with a higher amount, with 6%. As we grew, we now are at about $20,000 per pay period, a much larger amount. 2 years ago, I requested a ratcheting down to 4% because it was getting way out of hand for the hospital. 4% is where we've been, and the only reason I stopped at 4% was that because it still continued to go up, and then we'll take it with me. The only reason I stopped at 4% is because that's what actually was written into some of our sister hospital plans. They actually, for example, they had 4% written into the plan. The board there did that. They couldn't go up or down, above or below. They could only do the 4% because that's what was written in the plan. Here, you don't have that. You can do whatever you want, actually. That's at the board discretion.
I know that's only 150,000 roughly to save us, but we need to operate more profitably than we are. And we want to be generous to employees, however, that's more than almost twice of what I do in the rest of the job. In most corporations.
This will say, actually, I was trying to think, this is 3.64 is what it comes out to. You know, you're going to save $100,000 a year.
This is Tim. I just, again, I hear where you're coming from, Gene, and trust me, we look for every opportunity to save money. I just, again, this is my opinion. The board certainly can do what they want, but again, I just think with everything the employees have gone through with COVID and everything else, this is not a good time to go back and take money out of their savings. I mean, this is really what they're putting away for their retirements and so forth. And again, we have grown this dramatically. Again, with all the new employees, we've been really encouraging them to try to do this because this is a great benefit that a lot of companies don't have right now, or they don't pay as much as we do. It's a recruitment and retention tool as well. So again, my recommendation would be to not do this. I mean, I really do. Again, I understand where you're coming from, and I certainly support the idea of saving money.
Well, it's not going to affect the lower income people. So like you're at 14 grand.
It affects everybody.
You can match, or so overall, I can't see where it would be a big benefit for the hospital to do 2% rather than. Right? We're already generous, Tim. I mean. So,
Gene, I want to give the other board members a chance to speak on this, if they want to. John, Barbara, Charlie, any input on this or any questions?
I move that we accept the pension plan as stated by Chet Beadle, our CFO.
All right. So we have a motion. Then is there a second? We can have further discussion too. John, do you want to be heard on this?
I'll second. It got discussed in finance. I don't have anything else.
I couldn't understand you. What?
We discussed it in finance committee. I don't have anything else to add.
No, you don't discuss it in finance. You discuss it in where it's proposed by.
Yep. I'm just saying I don't have anything else to add.
Okay, but who's the one that proposed this? Where was it discussed? Which one is personnel?
Or TNT.
P&P. That's where it came from. It didn't
But
come
we
from finance.
But we did discuss it in finance.
No.
We sat in on board.
There's a motion.
Was it board
The P&P, I heard it because I sat in, but I couldn't talk.
I think you might have brought it up at finance as well, but it was discussed at board meeting.
Thanks, Heidi. Charlie, do you have any comments to add?
No.
All right, thank you. I do. I don't want to rip the rug out from underneath our employees. I think this is a sound program. I think it's a great perk for our employees. and they are working their tails off for our community, and they're doing a bang up job. And I think if we mess with this percentage, it sends the wrong message. It's not the message I want to send to our employees. So we have a motion by Barbara and a second by John to accept staff's recommendation. John, your vote.
Yes.
Gene?
Can I change my mind and say yes?
Yes, you can. Okay. Barbara?
Yes.
Charlie? Okay, I can take that as an abstention from Charlie. I vote yes.
Yes, I'm here. Yes.
Okay, Charlie's a yes. All right. All right. So that item is approved. That takes us to Bob Easterday and water treatment plant rotary screen replacement. Is
Yes.
Bob in the room?
Yes, I'm here. I'm next to Chet.
Thank you, Bob. Hi.
Yes. Yes. What I wanted to discuss briefly is the existing treatment plant was designed with what's called a rotary screen, which pulls things out of the waste stream going into the treatment plant, such as rubber gloves and patient wipes and things that would clog up the system, and draws them out, and it drops them into a black holding tank. The rotor screen is completely worn out. I've been welding in little pieces of metal, trying to keep it together for about 1.5 years, and it's starting to fall apart even more. So it is time to replace it. I did find it took me quite a while to find anybody who even makes rotor screens anymore. I did find a company in New York State, and I called him and I had a discussion with him. They do make one that would be they could make a direct replacement. It varies, says depending on what they have to customize for your site at $42,000 to $45,000. And but then also I had approached a number of other companies, and there is a new design out that instead of it just pulling those out and dropping them into a tank, which is hard to pump out every year when we get it pumped out. In fact, Thomas had finally refused to even pump it because once they pumped all of that product into their tanks, they couldn't get it out of their tanks. And so it's been harder and harder to find somebody who will pump it. This new device, this new design of water waste treatment plants, and they're made in many sizes for any size of treatment plant, utilizes a screw assembly that draws these products out of the waste stream. But instead of just dumping them into the black tank with the solids, it draws them up the thing, and it washes them with water and then drops them into a trash can. The trash can can then be hauled off every few days and put into the normal, trash receptacles. So it makes it less expensive for us to pump the black tank, and we have to buy one or the other. The challenge is that the screw assembly, which I forget the name of it, but you have the paperwork in your handout. It runs $60,000. I have an actual hard quote, and it's $60,000. So it's approximately 15 grand more. But what I'm asking for is approval to go with the better product. I sent an email to the engineer who designed the treatment plant, and he came back and said that yes, this new system works very well. He's checked with a number of facilities that have used it, and he highly recommends that we utilize it versus just the rotary screen. So not only is it being recommended by companies selling it, it came as a recommendation from the engineer who designed our waste treatment plant that it would be a very good solution for us. And that's it.
Thank you, Bob. Questions from the board?
it seems like in the long run, it's gonna be cheaper anyway because it's more efficient and looks better.
Yes,
So it'll save us money.
over time.
Yeah.
Yes.
So it's saying we can't lose by doing it. Can I, should I make a motion?
Yes.
Okay, I make a motion with the proposal. 65.
I'll second.
John seconds. Is there any other discussion? Does anybody else want to be heard on this matter? Okay, John, your vote.
Yes.
Director Parks,
Yes.
Director Casas,
Yes.
Director Bush, okay, we'll list Charlie as an abstention for now, unless he comes back on, and I'm a yes. So this matter is approved, which brings us to the architectural services seismic retrofit Greenboro design. Bob?
Okay, so, you know, obviously we've discussed this at length in our building and planning committee. You know, we're at a point where OSHPD has made the comments on our preliminary review. They're starting to call the architect and say, when are you proposing to have construction drawings to us? And he has kind of fended them off because obviously he can't start construction drawings unless the board approves it. We did have some discussions on his quote, and he added into the AIA document, because there's actually kind of 3 steps that we have to do to be completed through construction drawings. And one of them is like design development, and yeah, sorry. So right here, okay. We need to finish the schematic design phase, which is the 79,880, the design development phase, which is the 322,280, and then the actual construction documents, which is the 607,260. These all combined. There's also time spent during the regulatory review phase of the 65,940. In this document, he has made it clear that if we start down this road, and let's say we do schematic design and something changes and we want to stop the project and pull the plug, we can stop at any one of these steps. So in other words, if we get into design development and things just change, I mean, there's no knowing what that might be. It's just, what if? He says then we can stop at that point. And there's no, it's not like we owe all the money. It is only paid as each phase is done, and we can stop at the end of any particular phase if we were to change our minds.
One thing, Bob, though, there is a progress plan.
Yes.
That's how it's structured.
Right.
So of the $1 million, $1,075,000,
yeah,
it's actually 6%, I believe. You're going to read through it, but basically 6% of the total project per month would be the progress payment. Now, maybe more than the progress payment, you know, depending on what they did.
Right.
But it would probably be a minimum of 6% per month, according to this,
right,
as a progress payment.
5,000 a month.
Yeah, and he's, you know, I asked him because I said, this is a lot of money. This is a large commitment. And his comment was, is what you have to kind of look at is it's not just him. It's the architect, it's the engineers, electrical, mechanical, structural, all of this, all working on the project. It is approximately, you know, and it's going to take, I don't know, 6 to 9 months. And this is basically 20 people working on this project for 6 to 9 months. So it's not like he's being paid a huge amount of money. People are just earning their wages with this. So, you know, we're at a point where if we do not approve to move ahead with getting to construction drawings, OSHPD will cancel our application. You know, and so then we're back to square one as far as starting over with Oshkosh. And there are some unknowns. I mean, there's the bill. I mean, but you know, like Tim said, if we only need the seismic, the ED, and surgery, there's still the challenge of the 50-year-old building that needs all of its infrastructure fixed. So the actual structural walls, shear walls, and diaphragm that strengthen the building is actually a relatively small portion of this whole construction cost down the road. We can't continue to use this building for another 30 years or 50 years the way it is now. It's already very challenging to keep it alive. So, you know, we need to fix the building because it's old and tired. In this is also structurally fixing it for the seismic piece of what the state is asking. So basically, we need to proceed, in my opinion, with giving him the go-ahead to create the construction drawings if we want to keep our application alive with Oshkosh.
I think it's important too to point out again that, you know, again, if the application is closed by Oshkosh, we lose that 2016 building code issue that we tried so hard to get locked in, because again, losing that is about a $2 to $4 million additional expense that we'd have to come up with to meet the new codes for 2019.
Okay, what I keep hearing, it's 4 years old. How long are they going to keep saying 10 years from now? We're grandfathered into 2016. We might be better off if we spend the $4 million to have the current codes. And so, no, it's too cloudy. All I hear is 2016 saving some money. What money exactly was it?
Exactly what it is saving us is if we go to the 2019 code, the entire laboratory has to move inside of the acute care building. Okay, so, you know, probably but we have no room inside the existing building because every little space is already assigned to the bare minimums of what we need to accomplish the ED, physician sleep rooms, new restrooms, everything and that's still pulling administration out, gaining that space. Pharmacy's got to be bigger. They can't continue in the little. But if we go to the 19 code, okay, we have to do an addition onto the building of approximately 2,000 square feet, a brand new building, to bring the lab in. Okay, I mean, if money was no object, that would not be a big deal. There's a caveat to that. Right now, if we purchase a new piece of laboratory equipment, they bring it out, we place it in the building, and we hook it up. Company turns it on, and we start the testings. If it is in the Oshkosh building, every time you want to even replace one piece of equipment on the counter, it's a minimum of a 6-month plan review, architectural plans, submission to Oshkosh for anchorage, electrical requirements, a 6 to 9 month plan review before we can bring that piece of equipment in and put it in. So that piece of equipment, instead of costing, say, $50,000, it's going to be $80,000 to put it in by the time we pay the architect, do the construction project under Oshkosh. That's the disadvantage of having a laboratory inside the Oshkosh world. Now, I would love to have a new laboratory. Our building that we have in is not in the greatest shape, but it does work. It's allowed to be grandfathered outside of the facility. We do have to take the small offices at the end and create what's called a stat lab under the 2016 code, which has to do the bare minimum laboratory functions in case the lab in the back falls down and quits working. So that's one of the biggest arguments. Also, I think there's going to be more pharmacy requirements if we go to the 2019 code, which is going to mean that the area that we have designated for pharmacy is not large enough. It has to grow into that expansion.
It's got a number of them, and it's again, that new code is obviously still being
Let me
analyzed.
speak financially to your situation. Because I think that's important. Right now, at $19.3 million, which I have in the budget, I can say you can start this, we can pay for it. The money's already appropriated, if you want to call it that. The money's already appropriated, and the furtherance of that money to start the next part of it is already appropriated. Should you change and wait, I believe you'll be in the neighborhood of 32 million, and I can tell you that I would not give you any support for financing a $32 million project. Absolutely zero.
What about Tehachapi? Were you involved whenever they went from 30 million to 65 million to
It started out at
127 million?
It started out at 64 million.
Yeah, and then your plans end up costing 3 or 4 times as much as it was to start with. You're going to put us in bankruptcy.
Well, actually,
we can't.
The $64 million plans were very expensive.
We
got down to placing things on debt.
We have to be able to see where we can finish what we start, or we end up just the same as Tehachapi, not owning a hospital.
My only recommendation to you here of this financially is that you change, and Scott's still got to review it, remember that. You change the requirement for progress payments to actually what they do in that month. I don't like progress payments. I feel like you're paying in advance. I don't feel like we should have to do that. If he does the work's there in that month, you pay for it. If he doesn't have the work, you don't pay for it. With contractors, architects, just the same as far as I'm concerned.
We can apply for exceptions, and things can change. But we're just like.
Well, that's what I'm saying.
Okay,
You
2
pay-
years ago.
You pay for what, there's no progress payments. You pay for what is done on an ongoing
2
basis.
years ago, I heard you guys saying, "Oh, it's urgent! It's urgent! We gotta get these trailers and put them out there." $75,000 later, zero benefit. So why don't we look at some options?
What are the options to this?
The options could be, I don't know. Question would be, can we put a metal building at 2,000 square feet outside there?
No. We're talking about the hospital now.
Yeah, no, they make everything under, I mean, what are the options? What can we do? It's earthquake compliant.
Hey, Gene,
Yes,
the item on the agenda here is this contract with the architect. We need to focus our discussion just on that.
what I'm talking about is, do we want the contract with the architect? Is that what we want?
Well, we discussed it at length during the Building and Planning Committee, and if I can count votes, it looks like it's going that direction. We won't know until we actually take action tonight, but this is the logical next step.
Okay, then let's change it to, like you said, without 6% interest. I mean, it's gonna drag out for 15 years. It's crazy.
You need 6% progress fee.
Progress, no.
Yeah, I'm saying I don't agree with the progress fee.
Well, okay, again, this is a
I thought you said
draft.
6% interest on the progress. I'm not told.
Let me just add one thing. This is a draft. It's a marked draft. It is still marked up in a way for our lawyer to take a look at. I suspect if we would respond back to the architect that we don't like that piece and we would like to structure it differently, he probably would accept that. I can't speak for him.
Let me update that, Bob. The architect, Scott has gone through this whole contract. We've been working back and forth with Greenbow on this. It is not finalized. I mean, if there is a change that the board decides they want to make, we can still do that tonight. So, I mean, that's not an issue. But but Scott has gone through this. They have actually acquiesced to virtually all of the changes that Scott has put into the contract.
So we could cancel the contract at any point with no cost to us, other than Warriors Progress 2.
Well, I'd rather Scott answer that, but that was what the architect explained to me.
Okay.
That's standard wording in the architectural contracts, as far as I know. but I don't like it.
But you were saying we're putting 6% interest on the
Well,
entire amount.
progress payments,
Not in.
the percentage may be different, but progress payments
Oh, yeah,
are
I
standard
thought you said
AIA
6%
contract.
interest on the entire amount.
I just like to get paid for what they've actually done. That's what I like. But again, I don't, again, no, it's not my total decision.
As long as we could cancel it wherever the progress is, then I think we can see where we might not want to go where we're going.
And that's my understanding. That's what the architect says. You can stop at any point if it's the decision of the board to stop the project.
Scott's on the phone. Scott, do you want to address that?
There's a cancellation clause in the contract. Yep.
Okay, we didn't get a complete contract. I tried to read through it, and with so much line through, I thought I was.
That was the draft. So we were showing you the changes that were being made and that were proposed.
What it is the AIA document is a generic document, and you line stuff out, and you do it's done in what is done with all documents, so that you can see what's being lined out and what's being changed. And he left it that way specifically so we would fully understand what those changes were.
Just so I understand, Tim, who was involved in making the decision on what we're doing and how we're doing it? I mean, was the community at all involved, or was any board members involved, or was it, you know?
Of course.
Tim?
Board members were involved.
No,
all the board members were involved.
The definition of we're a government entity governed by 5 board members elected by the community. The community tells us what to do through the board members. We haven't been involved with it, and you put it in front of us and say, you know, you like it or not like it. But there should be a committee or someone looking at everything rather than just Bob. I have a little respect for him and he's very knowledgeable, but it seems like we haven't.
Gene, we are that committee.
Okay.
We were elected by the public to make those decisions. It's us. We're the ones who have to make this call.
Okay, well.
We can't get elected and then you know, nitpick to every citizen and say, what do you think? What do you think? Take a toll.
No, we can at least let some of them look at something. There's been no involvement.
They have been looking at it.
Even the board hasn't been involved. Has the board been involved in your decisions?
Absolutely. Every one of them.
Yes.
But a lot of it was prior to you being on the board.
Well, you've made so many changes since then. There's nothing the same as from when I was on the board.
I can't speak.
Okay. At this point, it seems like we can back out of what we back into right now. So.
My understanding.
Right.
All right. So are we ready to? Is anybody willing to make a motion to approve this contract?
So moved.
Second.
Director Blythe, was that Charlie seconding?
Second.
Yes.
Okay, we'll take Charlie's second. Any more discussion? Any input from members of the public? Okay, it looks like a procedural, not a procedural, but a kind of an interpretation of one of the board members' comments. So seeing none, then Director Blythe.
Ross, I'm sorry. There is a question in the chat section. Could this wait until after 7:58 is decided? Do you have to act tonight? Is there a few months' time available?
No, not with Oshkosh.
I do not believe that we have several months of time to wait with Oshkosh.
We don't know what's going to happen with 758. 758 may take a long time to get through committee. This was a bill that actually started almost a year or 2 years ago. That was put out as a 2-year bill. Okay, that could get squashed again in one of these other committees that comes down the pike. The point is at this point in time, we're still operating under the requirement that we must have this all done by 2030. If 758 miraculously gets through, then great. We just bought some more time. You know, again, but it also affects, you know, the areas that we need to upgrade in this hospital. As we said, what's in the 9-phase plan is what needs to be done here to meet that, as well as the infrastructure issues that we have here of dealing with and living in a 50-year-old building. And that's really what it comes down to. I mean, we've got to get started because it can take so long to get the plans done, and then the back and forth that goes on between the architects and OSHPD, you know, to get these things approved to a point where it's acceptable to them is a long, long time. So, you know, that's time that we're wasting, obviously, to get the construction started. We've got to get moving on this.
And honestly, if 758 is approved, that'll ultimately affect our completion date if we can draw it out that long, but it won't affect the drawings. It won't affect the plans. It won't affect the issuance of the permit. If we don't do it now, we're out another $2 to $4 million.
Right, absolutely correct.
Well, and furthermore, I believe from the building planning meeting that if we don't do, I think you said within a 2 or 3 week time period, correct me if I'm wrong, that we would no longer meet the 2016 codes.
Well, it's not that short of a time frame. Understood.
It was a timing of the essence.
Yes. What it is OSHPD is very clear. When you have submitted construction drawings, they have X amount of time to review them. You have X amount of time for corrections, X amount of time for review. There is a little bit of a leeway on a preliminary review, which is what we've had. But the comments came out on the preliminary review back in, like, what did I tell you in building planning, May or something? So we have not proceeded forward since May. And so OSHPD is beginning to say to the architect, when do you think you will have construction drawings? Even though there's not a finite, 160 days or whatever to the particular time frame between preliminary review. But if we drag it out another 6 months waiting on the bill, they will probably cancel.
The bill had 0 opposition, so the chances are it's going to go.
Understand? I'm only saying is that we can't wait a long period of time. Could we wait a few weeks? I'm sure we probably could. Could we wait 6 months? Probably not.
So, when you're talking a long period of time, I looked at the clock, and I'm sorry for keeping.
That's okay. Okay, that's all I have, Tim.
Okay, John, Director Blythe, your vote?
Yes.
Director Parks?
No.
Director Casas?
Yes.
Director Bush?
Yes.
And Elliott votes yes. Okay. Oh, I need to locate my agenda one more time. All right, this is the portion of the meeting where directors may make comments on items not appearing on the agenda. Director Blythe?
I actually have a lot, but I'm not going to say anything because I'm just too pissed off and frustrated. Yeah. Sorry.
Okay. Director Parks?
Back to my question that as far as Tim, I think was in agreement that we're supposed to be posting our recording videos.
No, we're under no requirement to do that.
I didn't say we're in the requirement. That you have been saying that they are posted and they are viewable. Is that our policy or not our policy?
And so, Gene, you are in fact then, by bringing this up, making this as a referral to Tim to look into?
Okay, and the other thing is, whenever I was on Zoom, I tried to record it myself there, and I couldn't get us to accept me recording. Now, we're recording it here, and we can give you permission to record it. Are we not giving permission Do you know, Tim?
I don't believe we can give permission to somebody else. It's our meeting, so therefore it's the hospital's. I don't think you can give.
It's a public. The public wants to record it. What do you mean?
Public, yeah, the public can find a way to do that off their screen. They can certainly, or off their computer, they probably could.
Well, they
But
can't.
not something I don't believe that Zoom allows you to do.
Yeah, it's technically possible with Zoom.
Is it?
If somebody wants to record the meeting, then they can request it. The moderator will either grant that permission or not.
Okay.
So it's technically possible, but I think, Scott, is that something that you can report back on? I mean, maybe you don't know off the top of your head, or maybe you do. Is it appropriate for the public to be able to record their meetings off of our device?
Yeah, so the public has a right to record by audio or video any board or committee meeting. So if they want to do it off of Zoom, they can. If they want to come and set up a camera in the room, they can.
Thank you. Okay.
So we would give them permission. We should, then, if they have the right to record it.
They have the right to record it. Gene, whenever you call somebody and they say, please wait for the next available operator, your phone call may be monitored or recorded for training purposes. They're required to say that. If I have anybody on the air, I'm required to say, you know, you're on the air, you could be recorded. That's why our,
Is it?
you know, it's a courtesy. It's more than anything. If somebody wants to, the problem is, if somebody walks into the room, we have public meetings that are open to the public. They can come in there and participate in each and every meeting. And what I'm saying is that, you know, you can go in there and maybe somebody who's in the public is sitting there saying, I don't want my kid, hey, you know, I don't want them on a video out there. You know, they have every right to deny that person the right to do that.
All right, let me just say, these are public meetings. Anyone can do a video or audio recording of the meeting, and members of the public who are there are deemed to have consented to be part of the video. I'm sure that Barbara remembers this, and maybe Chet and Heidi remember this, and Tim may as well, but several years ago, we had a member of the public who came in every meeting with a video recorder and recorded every minute of the meeting. It's allowed under the Brown Act. It's not really a question. If they want to record it, they can.
So the button that says that we're giving permission for the people to record it should be on. We should be able to let them record it.
They've never been denied.
Well, no, there's a special button. Carrie, is there a place in there? Are you familiar with it?
I'm not familiar with the button on the public end or a participant meeting.
Yeah, participant.
On our side.
Yeah, we will research that, Gene. Obviously, if we have that ability to turn that on, we will.
Okay. All right. Thank you. I think that was it.
Thank you, Gene. Director Casas, any comments?
No, I have no comments. Thank you.
Thank you. Director Bush?
Just once again, thanks, Tim, for the reports. Very, very helpful. So I appreciate your doing that, and congratulations on the new start. We look forward to more.
Great. Thank you.
Thanks, Charlie. Okay, I have a few comments too. We went through the entire meeting and we didn't get to be the cheerleaders for the SNF. They got a 2-star rating now, up from 1. You know, admittedly, they're deserving of more than that, but and I know that they will get there. We're on our way to 3 stars, but congratulations to everybody who's involved in putting us on the record as a better facility. It is a great facility, and you know, a 2-star I don't think is reflective of what's really going on there. But you know, you look at that SNF, it's a shining example amid the COVID pandemic of how to care for patients and minimize exposure to virus. We've made huge efforts at infection control. We still have no patients with positive COVID test results, and I just wanted to say kudos and congratulations to everybody involved in making that happen. We've got also,
Day
Go
by
ahead.
day process.
All right. I know it's got to be diligent every day, but we're doing the right things, and I want to thank you. So we've got our strategic planning, where we're examining really the operations and services of us and the world around us, and developing goals is basically a roadmap to how best to ensure the district's success into the future. We've got Valley residents have the opportunity, and staff, to participate in surveys, which is very important information for the success of the strategic plan. The information from those surveys is going to go into making these strategic decisions. So your input's very important. And again, I encourage all the board members to encourage everybody they know to participate in that survey and help get the word out. On the building plans for the hospital, you know, the board conceptually approved a 9-phase modernization plan for the upgrade of the hospital. Now, we took this action in the Building and Planning Committee meeting. I believe it was back in May. And it'll achieve the seismic compliance mandates from the state, but even more importantly, it'll upgrade all the infrastructure that's crumbling around us in our 50-year-old building. 9 phases of this are necessary to allow the hospital to remain fully functional during the construction process. So it's a complex construction project to allow the hospital to continue to remain as a fully functional hospital while the construction's going on. It's not an expansion, it's just a modernization, and it's basically within the footprint of the existing building, if we can stay under the 2016 code. The emergency department will be greatly improved. The price tag, the estimate that we're looking at is 16 million, perhaps 19 million over a period of years, if because of inflation, because just costs will go up over the years. So the estimate is between 16 and 19. And this is compared to the 38 million that was involved with Measure Q, a substantial reduction. And we're striving to pay for this with our existing resources. We want to live within our means. We want to pay as we go. We're not seeking voter approval of bonds to pay for this. And there are no proposed tax increases. And this hasn't been discussed publicly other than in the building and planning meetings. And I'm reiterating these comments because I think it's important to share with the public. Part of the cost savings that we're achieving with this is the removal of those office trailers. Developing that vacant lot across the street with the ongoing costs and leases of the trailer is just, in hindsight, too cost prohibitive. We just don't have the resources to do that. And so we're looking for other options for office space, and which will allow the administrative functions to be located, perhaps offsite. And you know, if we don't make these changes and relocate these administrative functions that are now inside the hospital, it's going to be difficult to make the improvements and keep us fully functional. So that's basically what's going on with the construction plans. And just a note to all the district staff, you know, you've been on the front lines of the battle against the coronavirus. You do it every day. It's undoubtedly stressful and demanding. And early on, and still, there's a lot more questions than there are answers. Yet, the community is reliant on us, on you frontline folks, to be there. And you've delivered. To date, you've delivered, just like you always do. So I, as I'm sure the rest of the board, are grateful and appreciative of your professionalism, your dedication, your competence, and your bravery. Perhaps you view yourself as just doing your job, but to me, and I think all of us, you're our heroes. So I want to conclude with that, and thank you for a good, productive meeting tonight.
Thank you.
So with that, no, go ahead.
I said thank you.
Okay, Tim. All right, with that, folks, we're adjourned. Thank you.
Right.
Good night. Bob, if you've got a moment, if you can come in. Bob Easterday.
Will do.